That's it. We are live. We are live to talk about the RFK announcement, RFK and Oz. It's technically, actually, let me rephrase. RFK and Oz were together along with others in Florida. Maura organized the event at Nicholas Children's Hospital down in Miami. Carter and I were there. Small group. And the announcement, there's multiple layers to the announcement. So so Maura joined us. We decided Tuesday, we were debriefing about it, the three of us. And we decided that we were going to completely change our week and unpack it on the live stream, in part because I think we've seen System B at its finest in terms of what they've done with this announcement. So what I'm going to do is I'm going to play
what the announcement is.
Well, that's what I'm going to share. I'm going to share my screen and do this.
So I can make a little update, which is the event was put on by AFPI, America First Policy Institute, and HHS, and the Nicholas Children's Hospital, and Cox Consulting, and the Florida Health and Nutrition Coalition was teamed up with them for the event.
Thank you.
Yeah.
I did not. Okay, here we go. So let's share the video and let me play it. Hopefully everybody will hear it. See how many technical difficulties I can run into today.
Yeah, why don't we just say what the announcement was?
Sure, but I was excited to show the video.
Okay.
But that's fine. Go for it.
Ellen has an exclusive video. She was sitting right next to me in the press event filming. So all the big cameras are in the back, and she's literally right almost in the front row filming the press announcement.
But now it doesn't want to come up for me. So let's talk about what the event actually was. And then I'll get this thing rolling.
Okay. Do you want me to speak?
Yeah, let's tell everybody what was announced.
Well, here, I will hit that very quickly. I was very diligent in preparing for this, even though it seems that the technical challenges we faced. There were four. So the first was CMS sent a memo on Monday to every U.S. hospital directing alignment of patient menus with the 2025 to 2030 dietary guidelines for Americans, so the DGAs, under the conditions of participation, which is part of the Federal Register. So they said, if you want to be a Medicare, a Medicaid participating hospital, you have to align your patient menus with the DGAs. The federal mandate in everything but name. And it would be part of an audit process. That's number one. Number two is the Florida Institutional Procurement, and that was national. Just to be clear for everybody, that was a national memo. Number two, Florida Institutional Procurement Partnership Pledge. And it was 5% local farm sourcing of the food for the hospital in Florida. Every hospital in Florida, they're asking for a pledge. And at that meeting, Nicholas Children's CEO announced that his hospital, he signed that they would commit to 5%, procuring 5% local sourcing with an increase of 1% per year. And that is a pledge that's open to all Florida hospitals at this moment. Number three, this was not so much an announcement, but a little bit of a statement that I have to be honest, because of my knowledge, is kind of confusing. So I want to clarify this while we're on the call today. We're on this today, is Oz made the announcement that for the first time in history, starting April 1st, CMS will reimburse app developers and digital technologies providing personalized nutrition services. And that is something I really want to clarify, because that was kind of a conflation of some things that could be taken very much out of context by folks. And then the final thing that was, I want to say, announced, it's not a new program, but it is a program, but it was brought to light contextually by RFK, was the military pilot that's underway, which Hegseth brought in Chef Robert Irvine to redesign military food. It is in place in 5 bases. They will have 20 bases doing this by the end of April, and they plan to have all bases by the end of this year under this program. They have replaced processed institutional food with real fresh food, because what they found is that soldiers were throwing out the majority of the meals, and then they were going out and buying, convenience store food, everything else. And the results, according to this announcement, were lines out the door, that soldiers are eating it, and that the cost dropped from $18.50 per day for 3 meals to $10 per day for 3 meals for real food. That was the announcement. There you go, Carter.
Yeah, so the event itself was actually designed and conceived, like we were part of. I'm Maura Plant. I'm the co-founder of the Florida Health and Nutrition Coalition, and we were invited to participate in creating this event together. And it has like multiple stages throughout the day, and different people were involved at different moments in order to bring this to fruition. But the big concept that really was launching it all, and we're the Florida Health and Nutrition Coalition, was to bring the local Florida farmers and procurement direct from local farmers into this health supply chain. And so we run a lot of food as medicine programs across Florida. There's 9 regions of Florida. We have 9 teams running, basically, using food as medicine to reverse, diet diseases that are chronic conditions and diet-related diseases. So we actually have teams that have already, are already running programs with clients using local food from farmers as a piece of that sourcing. So we were really excited to kind of plug in and demonstrate, not only is Florida farms and Florida farmers, basically 15 to 18% of the U.S. production. People don't really realize how big of a farming community we are, but also marry that back into healthcare. So we were really looking at this as an opportunity to get some of our farm food, regenerative, soil intentions out into this bigger discussion at the national levels, and then really map it back into exactly health outcomes. Like, how are we delivering BMIs to come down, A1Cs coming down, which makes it food as medicine, because if you don't have the outcomes, it wasn't food as medicine. So we're standing here at the corner of like food is health, food is medicine. And that's what Florida was really brought to the table for. And that's what our team was doing. We brought about 50 people with us and flooded the press event so that it was really a joyful occasion. And you can see that in the pictures and the response that RFK and Oz and Kelly Means and some of the people that have been getting beaten up were actually able to feel some love from the room, from people who appreciate, what it is that they are propagating for us. And of course, we have Healthy Snap rolling out in 2 weeks, April 20th. And we also have, these DGAs that are really ground shaking, because they go into everything, every RDN, every school, every nutrition education program. They're all tied back to the dietary guidelines. So
so let's maybe step through these systematically a little bit. So the trigger to source local for hospitals, did that come out at the national level or Florida up to national?
It's a really good question. We have been working on it in Florida because we were hearing about MAHA boxes, MAHA funding coming down, and there's a rural health transformation dollars coming down. And so we are really activating farmers in order to rise to those federal dollar moments, right? Like, a farmer's never going to move until you call them up and you say, I need 7 pallets on a truck delivered to this place by this time.
Yeah. That's
when they're like that transaction rate. They don't have time to, engage in, conversations. They're really very busy.
Those were both triggered. The Rural Health Initiative, which was $50 billion set aside, and that was pulled out of Medicaid.
So we started talking in October, and getting our farmers aligned to do this across Florida, beginning these conversations.
Yeah, I just want to put people through it so they understand where this is coming. So the Big Beautiful Bill both introduced around that time MAHA boxes, which was a little bit of a shift away from the 1115 waivers, and then also assigned $50 billion to address rural health, which was offset from reductions in Medicaid dollars, or redirects. That then triggered that over, and then there were some parallel efforts with American Forest Policy Institute, which is a political action group that Brooke Rollins used to lead. Brooke Rollins is currently USDA Ag Secretary. And American Forest Policy Institute, to a degree, is they're pulling together and marshaling those resources. And then we've got groups locally, like what you do, like you more do,
the state level.
And then I think we've also we've got other colleagues up at Appalachian Regional Healthcare that have been thinking this way. And then there are many other states. And so these two have sort of met to say, let's do something about it. Somewhere, let's pretend that sort of said, okay, let's focus on hospitals. And then it leaned into Florida to say, let's announce out of what's going on in Florida, the desire to source 5% pledge that they will source 5% of local fresh.
Yes.
Okay, so anything in the setup there, like
good setup, very good. So, and
I just want to make sure, because we're all deep in the middle of it. We just want to make sure that other people are aware. Okay. So the
Appalachian Regional Health model was the first to go before us all. So they're in Kentucky, Tennessee, and they established a model where they were kind of ganging up local farms, kind of doing a group buy purchase opportunity by going through a restaurant like delivery company that's called What Chefs Want. And there's kind of like a Cisco. We have Cisco here, mostly Cisco here, and USA Foods type of people. So anyway, the farmers gang up through the restaurant delivery supply chain, and then they arrive, right on time, on demand for what the chefs are doing at the regional hospital. So you have patient food in their rooms, you have the cafeteria, and then you actually have also people outside that are doing community outreach and like mobile farmers markets. And so all of that is now being sourced through this second RFP kind of supply chain. Most of these hospitals, and theirs too, have these 10-year commits with some, Sodexo was the big one. Yeah. Some contracted entity that they said, you're going to do our meals. This is how we save on efficiency and costs, long term. So they actually have to carve out a separate bucket of dollars to access local fresh produce, which we find is the most nutrient dense, which renders the best health outcomes the fastest.
So one thing I want to add to this you probably don't know is the CEO of ARH was an event we ran with Eric Adams back in
from New York
back in 2022 in Brooklyn, just when Eric Adams became mayor.
Love him.
He was running at the time, or he had won. So Eric Adams, as people may know, had diabetes and reversed it through his diet. Rachel Atchison was part of his team. Rachel and Eric Adams were at this conference we had, as was Holly, the CEO of ARH. And we cooked up real time in the room, in that meeting, the idea where ARH was thinking that they needed to take some responsibility to this, knew that it might actually cut off some of their revenue, and were inspired in part by what Rachel was doing, going to do. And the Sodexo relationship was sort of a byproduct of some of the success up there. So the reason I raised this story is there are a lot of people on the ground like you who are the people that are making this stuff real enough so that in the Eric Adams case, he was a patient. I mean, he was patient zero in this conversation.
Yeah.
And I think that as others have come in along the way that they've been able to build on the success of the people who are on the front lines like yourself, who are making it happen and making it real enough that it's not just theoretical, but it's actually something that can be done. And they're
they did amazing work. Rachel Atchison and Eric Adams in those hospitals in New York City. They had like 29 options of plant-based meals that people could pick from. And they were like Ethiopian and Vietnamese, not just like Italian, or like they actually invented new ways for people to have bowls and interesting things that allowed them to try new flavors without, suffering for taste. I would love their playbook. I met her in Buffalo, New York, at the Buffalo Niagara Medical Complex. They had a medicine conference there, and she was really just coming out of the gate. They were moving from like 13 to 27 meals to like 4 hospitals to all the hospitals, and that's amazing. So Holly from the Appalachia Regional Health was sitting at the round table, and she was literally between RFK and Callie Means, and she was the model that was being kind of demonstrated to the Florida hospitals and to FDACs, and saying, every time they had a rebuff, well, we can't do that because Holly would say, well, we solved that this way and that way. So she did a dynamite job.
So we've got, the other thing I want to stress there is that there are a range of people there that have been involved. The people like yourself, and I think probably we'll find in every single state now that there's similar kind of people, different degrees. And so the two big things here that this does from a federal level is it basically gives you more agency to sort of control, to say, for all the people in every single state that's pushing it forward, to push forward and say, now we have top cover out of HHS on this issue. So you want to play this, Ellen?
Yeah, let's now that we've teed it up, and now that I've gotten past my technical fun, and it does look like we successfully, I'm not sure how many people we lost with my snafu, but we do have a ton of folks on, so I think they quickly got the new stream key. But so it's just a snippet. This is just a highlight of the announcement.
Is that they have now, today, one of the announcements we're making is that they have now signed an agreement to bring in locally produced food for this hospital, 5% a year, increasing by another 1% every year. It's going to benefit local farmers. But it's going to give the children in this hospital nutrient-rich food.
So I'm going to pause there because I want to make sure we hit on that nutrient dense. Yeah. But I think it's important we spend time around the infrastructure opportunity that exists here and the infrastructure risk. But the fact that he said nutrient dense food and he didn't say healthy food, to me, like if I hadn't been live streaming, I don't know, I would have maybe reacted differently. But I think it was a good thing I was holding my phone and live streaming because I didn't feel like I could do anything except hold the phone and live stream.
And we know that our friends like Aaron Martin got in there and really taught him about nutrition density.
Exactly. Like Eric Smith with Audacious, like and Carter and I knew that was happening in the background last year. Like there's a lot of this has occurred. Like there's a lot of
you did it.
Well, there's a lot of front-facing, partisan, blah, 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 right? And I know I get flack from lots of places about showing up in rooms, right, with certain people. And I always remind everybody, I have been after health, restoring human health, fixing this for 3 decades, really hard for 2, and with Carter last 2 years before that working on transformation. So I'm not going to keep myself out of understanding where these opportunities exist or putting, think about it, by having people like Aaron and Eric in the room previously with these leaders, they now know to say nutrient density. Now, whether they understand how to execute that doesn't matter, because they're putting that out saying this is what we need to accomplish. Completely different, right? So I'll keep
And the other announcement that we're making today is that Dr. Oz sent out a health and safety notice, every hospital in this country at 11 o'clock this morning, asking them now to align their food purchases with the dietary guidelines in order to enjoy continued eligibility for Medicaid and Medicare payments. The fact that it's now essentially a federal mandate. But it's something the hospitals wanted. It's something that they needed, and we want to do this very, very quickly. As Dr. Oz pointed out, the food in hospitals is so uniformly and appallingly bad that it is now a pejorative if you tell.
It's a memo that reminds hospitals that under the conditions of participation, which is the most important tool we have, which is actually how we pay hospitals for the patients they take care of in Medicare, that they must ensure that the menus and diets meet that the individual patient nutritional needs in accordance with the recognized dietary practices. Those dietary practices have changed because Secretary Kennedy and Secretary Brooks Rollins have at the Department of Agriculture have pushed through a change in the dietary guidelines for Americans that now must be applied in hospitals. That starts today in Florida. This will empower every hospital in the nation to align the food that they serve to patients in the way that they're supposed to be serving those patients, not just with the scalpel blade or medications being infused, but with the true healing art of the food that we serve them.
Food is health. He said it. System B, we need to move to System C. Just saying.
Prioritizing real foods which heal you will allow patient menus to adjust dramatically, and that will start starting today. Reducing patient exposure to ultra-processed products, which are designed to prolong the shelf life of the product, but they do not impact beneficially the shelf life of the human taking them. All of these are opportunities, especially if you bring a culinary flair to this. So the food tastes good and people want to eat it, they'll keep eating it. And that's the triad of success that we're looking for.
So I do think as part of our conversation, that last point he makes, I think is where a lot of people will say not so much, which is if they like it while they're in the hospital, they'll keep eating it. And Maura, you deal with this with your participants all the time. It's like it's access to it, right? For a number of different, like affordable nutrition is not built outside of the hospital yet. So you can force a hospital to do it, but that doesn't mean that affordable nutrient dense food at scale is out there yet, right? So I'm just we're almost done.
This is where a lot of the pushback happens, which is, humans like what they're already used to eating. And so you can't just pull it from them. First of all, it lacks dignity. It's not, it's disrespectful. It doesn't follow your cultural heritage, right? All of those qualifiers. And so our approach, and many people's approach, is not that. Our approach is, let's take a journey together. It may look like a 6-month experience. We go in as a tribe. There's like a community of us that are going to change our lives together. We call it the healthy food prescription. And we go through this process of educating, onboarding new skills, new competencies. We taste menus together. We try out different things. Ellen, but you can talk about how you taught them to make a shake, and they can actually try different things. And there's different tastes.
I mean, actually, while we're on this, I probably will pull up a video or two, since I have it on my computer here, of maybe like a participant. But on top of that, right, is the point too of what broke my heart with your participants is that there are a number of folks that can't afford, even if they learn to like this food, they go through your program, right? Whether it's when they get discharged from the hospital, whether they get into a transition of care program that includes this, right? Once that program that the downstream healthcare system funds goes away, if we don't fix the upstream food system, we have a disconnect. So, and again, we're focused on downstream on this.
This is where the healthy snap rolls in too.
Wholesome foods that come out of the ground the way when you eat them. Food that is not designed for the product itself, but produced for your health, and adopted with a measure of culinary insight that makes it palatable and desirable. If done correctly, it works. We have evidence of this from the west coast of Florida.
So there you go.
So that's what we call medically tailored meals. In the food as medicine world, this is a lot of research back behind this. And there are standards that have been established for many years by the Food as Medicine Coalition. that have been doing it for 30 years, especially out of Massachusetts forever. And so we know what to feed people who have diabetes. We know what to feed people with renal failure. We know what to feed people with cancer. Like, these standards exist. And the question is, like, in this new alert, it says that they have to develop standard menus and therapeutic diet protocols. So we're really looking at like a standard operating procedure book that adopts these new dietary guidelines and really needs to bake in the literal Food as Medicine Coalition's MTM standards. On top of the sourcing and the procurement from local farms, which has the most nutrient density. So it's actually kind of like both and. So for us, we look at this as a major win. This is a national major win for Food as Medicine. And then you'll actually see health outcomes. So what will render when you do it in these ways is it actually just flows naturally, that people have less time in a hospital. That's how you find the cost effectiveness on healthcare utilization. They don't come back to the hospital as soon or as often, and they don't come through those emergency rooms as often. So you're actually saving a lot of hospital healthcare utilization.
Oh, hold on a second. As a result of the inpatient change in meals, or of just getting them overall in their diet? Because I mean, is there any any data that? Let me say it a couple ways. So, one view you can take of this is sort of broken windows theory. So the idea on broken windows is, early on in New York, they reformed themselves by ending little petty crimes that stopped bigger crimes. Like, people, if you let a lot of petty crimes go on, people are like, well, I don't mind if I upscale that. So they sort of broken windows, fix the broken windows quick, and it establishes things. So one view on this is, instead of hospital food being a pejorative, if it's good, then that basically says, well, when I go to the hospital, I get this better food. Maybe when I'm at home, I should have this better food. So that's one step in terms of its signaling value. In terms of actual treatment value, you've made a lot of mistakes before you showed up in the hospital that now have given you a chronic disease. I'm a little wobbly on whether, other than very specific acute disease cases, whether there's strong enough evidence that says for the 5 days you're in the hospital that this changes outcome. Is there data that says that?
Yeah, we have data around cardiometabolic disease, diabetes disease, and other like pre-surgery, post-surgery effects of like loading in with medically tailored meals, and actually the healthcare utilization cost savings. So there is a bench of research around that, both in the hospital and out of the hospital, especially out of the hospital, like post-surgery.
Yes, post-surgery.
Critical moment, in your health. So what we heard in Dr. Oz was sharing, Kelly Means was sharing, RFK was sharing, like, why are we giving diabetics who just had a crisis in the emergency room, which can be like an emergency spike? It doesn't mean they've eaten horrible all their life. It means that they had a like one serious significant problem, either too little or too much, right? So now you end up in the emergency room, get leveled off, and now you have to kind of onboard 2, 3 days, 4 days, could be 5, back out of that crisis. And during that time frame, they were saying they were giving them like hamburgers and French fries and, crap that diabetics don't eat. And, sugar sweetened beverages like sodas. And so in Florida, they can't argue the no sweetened beverages because this is a sugar state. Our state grows 1/4 of the world's sugar. We have it right here in Palm Beach County. We have U.S. Sugar and Florida Crystals, and they fund a lot of great charities and they fund a lot of great entities, including ours. We've done a lot of work with them. They're a farmer. They're considered agriculture here. And they also grow rice, do a lot of other things, but they also have, we really, the state and politicians here are like on anything anti-sugar.
Well, but I want to build a little bit and test this back and forth. It strikes me that some people will look at this and say, look, the inpatient stay is short enough, and those examples are, happen. But in the grand scheme of things of running hospitals, is this the priority? So that's a perspective people might have. I think.
Yeah, our hospital exec that partners with us. Her name is Kim Seiswick. She was the VP of Community Services at Holy Cross for 35 years. And we were talking about this yesterday. And what she clarified was like, we really don't give them soda. What happens is the patient's family goes down to the cafeteria, grabs the hamburger and the soda and like brings it up. But we don't police that either because we really need to see them have nutrition go in their bodies, in their mouths. And, you know, this is kind of part of what happens in hospitals is family care through food. Let me help you. Let me bring you McDonald's, you know, let me bring you comfort food. And so actually that is some healing, you know, and anyway, I can't argue. That's not my experience, but I do know that they just released this new, this is the Medically Tailored Meal Sustainability Blueprint. And basically it's by the Center for Health Law Policy and Innovation at Harvard Law School and the Food is Medicine Coalition. And they're really, really excited about releasing this. This is how you actually put together all these medically tailored meals, the medical necessity, the medical benefit category, the fiscal consequences. And they're always tied to the economics and the ROI are always tied to fewer repeat visits to the hospital, shorter stays in the hospital, shorter long-term stays after the hospital if you're going to offboard into something, and then fewer emergency room visits. That's the healthcare utilization dials that they're looking at.
So in terms of how you're often being exposed to people that need to change their diet.
Yeah.
How do you, because they do spend time in the hospital, and it may just be an episode, how do you see this will help them realize, boy, I really should make a change outside the hospital? I mean, is there,
if it tastes good,
wrong?
it has to taste good. It has to be like, oh wow, that's quinoa.
Pause for just a second. We have a number of comments coming in.
Okay.
And I feel like we should take a moment to, because some of them are getting a little bit stale.
Okay.
And even if we decide we're going to keep going on this and come back to them, I just want to acknowledge these folks' comments, because a number of these folks are farmers and on the ground. When we talk about,
Go with them.
So we've got Samantha Brooks who says, and this is very true, and I know it's because of what I said when I said we don't have affordable nutrition or nutrient density. I didn't explain that the way that I meant to. It's more nuanced than that broad statement, but very good point, which she said is local farm food doesn't have to be expensive. It's the supply chain intermediaries that drive the price up and more middlemen. And I know, Carter, I'm just going to throw all these out there and then we can hit on them how we want. Sue Woods, who is like,
hi, Dr. Woods.
Really,
Dr. Sue.
She commented that she's very excited about this. Very excited. As is Stacey Mays. There's tons of people that are like, this stuff is exciting. And so Sue said, can those step down patients be given healthy food vouchers? I think that's a really good point, right? The next, Holly Stoltz said, 5% seems like a slap in the face. How's 5% going to turn the table? Give us health outcomes.
Oh, it's a lot.
How can you show success with only 5%? Is there data to back up improvement at 5%, 1% increase question mark? And then currently less than 3% of every plate in Montana is sourced local. So, right, we have an initiative that by 2033, 33% of every plate is local. Hefty lift? Absolutely. But all valid points. I don't know, Carter,
if you think about an F&B beverage, if you think about
Mm-hmm.
an F&B budget of a hospital system for a year, all in, including all the community outreach and all of the food that they buy for the cafeteria and all the food that they're buying and negotiating for the patient food, it is a massive, massive, massive number in terms of like in relation to their overall care and their overall expenditure. It is not small. So 5% of that, it's not just 5% of patient food, which represents about 20% of a hospital's actual food delivery. It's actually much more of it is in the restaurant and in the cafeteria and in these experiences and the staff and the employees and all of that. And so this is all changing. All of that healthcare, all of the health effects of eating better is going to be changing like that.
Yeah. And just Sue built on what she said is, and I really do want to spend time talking about the infrastructure opportunity here when we talk about this, kind of this System C build. But Sue hits on an important piece with Kitchen System C, which is the outcome is relative to staple produce being available to the lower income demographic, which is what I was hitting on, Maura, with what broke my heart when I came to record your your graduates. And the farmers are being given incentives to produce this product, in turn, a controlled distribution going directly to hospitals and households in need. This is an accountable way to ensure nutrition is reaching all. And then Bob Jones jumped in and said any food cost in the U.S. is average food cost in the U.S. is $5.89 per patient per day. You get what you pay for.
Yeah, we heard it was, I guess it was like $6 per meal per person on those 10-year Sodexo contracts.
So basically, I feel like I need to give my seat up in this call, and like those folks need to jump in and take my seat.
So, but list. I want to, from a System C viewpoint of how we build scale, I think my interpretation, so there's a little bit of opinion here, is there's a signal value to this. If hospitals are prepared to make a change in this direction, it opens up supply chain. There is an issue of getting supply chain to work correctly, and so that has a coordination value. We should put together the F&B budget for all the hospitals and say, what is it? But that all of a sudden, I bet if you added up that number, it's a 10% demand, 15% demand increase for local fresh. So that's that.
Yeah. Oz estimated around a 5% increase over, so it would be like 105% of itself.
So we should probably calculate what that number is. So that's thing one. Thing two is if you're in hospitals and the meals are crappy, it sort of sends a signal that it doesn't matter. So there's signal value. The second part is that fresh local is very good. Fresh local is not the only way to get good. And so I think a little sensitivity on saying that the way you get better nutrition is solely fresh local. I think that's, and I don't think that's exactly what people are saying. We want to concentrate on what the human-based outcome is.
And that's the chef side and the taste part. So taking these beautiful ingredients and actually making them into a palatable meal that we are like, our taste buds go, yay.
Which I think the Unilever's purchase of McCormick, I haven't had a chance to read through that yet, but long ago we thought that McCormick was an interesting play here because they can take otherwise bland food and simplify it so that can with
herbs and spices and sauces, so make it interesting.
But then I want to shift to another thing that we need to really respect here is I frequently hear phone calls from producers saying we would do anything we want but we don't get the premium because there are all these other people involved that take all the money.
Middlemen.
Well, the thing is I know that middlemen sound bad, but middlemen make the markets work. So unless I can be at my house and say I want to buy things. If I take the normal shopping basket that I buy at the grocery store and bought 30 items, would I need to make 30 separate trips to different places to go get it? So there's a function served by that. And I think
we have hubbers. They hub. So you have farmers, growers, and then basically packers.
Yeah. So I think
the packers mix and pack up a box, and that's what we're using that we bring to our clients, like mixed boxes. That's pretty much how it's done across Food is Medicine.
And you get other problems. In there, like if you have seasonality for vegetables but people want consistency of vegetables, then when you pick it, 10% of that may have to come from a farther away location. So there's a practical, as we think about solving this problem, it would be more helpful if we get away from, well, I'm the grower and you're the middleman, and I don't like the middleman because you take some charge of the fee, and the middleman saying, well, what, I'm supposed to cross-dock this for free? Like that, they're all involved in that. And so instead of sitting there fighting over which part of the pie, the notion we have been discussing is, and it's almost independent of what the per unit cost is, if $1 more spent here eliminates $4 in healthcare, that's where the money's coming from. It's
absolutely.
And now we don't necessarily. I don't think we have all the evidence on conventional agriculture or commodity that when you move to regenerative, you can actually reduce the cost on commodity crops. It's a challenge. Bob Jones knows this better than anybody. It's a bit more challenge in specialty crops because you have the other burden in fruit and veg that it goes bad quicker than corn and soy. But so it has different kinds of challenges, and it also depletes its nutrition more quickly after harvested. But the thing that if we all believe this, what I take away from the Kennedy announcement is HHS is no longer in the way of trying to solve this problem. So we want to get out of the way. And that it's now up to the entrepreneurs to think through how to make this affordable so that hospitals want to spend 10% or 20% or 30% of their F&B budget once they get introduced to the idea, through the 5% mandate. They're sort of forced to get introduced to the idea, and then they may very well find when they talk to the local producer that they can affordably pick up 10% of their supply, and that it helps them reduce their readmits, because when people go home, they don't go back to eating frosted, or I don't know, Count Chocula or something. I don't know what.
Cheerios. So I have another little layer for your algorithm to put into your math equation, which is that from the minute I get my food to my diabetic who's never eaten lettuce, I will actually be told, like, I don't eat lettuce, that kind of thing. And men, these guys, they're like, I eat pepperoni, Okay. So I actually order from Cisco, the chef quality, highest chef grade. And what I'm doing is they're literally cutting it in the field. I'm actually receiving it within 2 days, and it actually goes into my client's car to go to their kitchens. And it's literally like two pieces of lettuce that's the size of your arm, because that's restaurant quality. Okay.
Yeah.
And it's that local density, but it's flavor, it's taste, it's freshness. It's like you can literally pick your teeth after you eat the spinach. That's this level of quality that it just come out of the ground. So the longer days you go, 5 days, 6 days, 7 days, no. You try to freeze it and give it to me? No. You try to can it and give it to me? No. We really need that freshest, beautiful, flavorful, that makes people who never ate it before want to eat it. And they will eat it. And then they eat it and they want more of it.
Okay, hold on a second. So I don't want to deep dive, especially Bob's listening. So do you over-index that high quality early to convince them and then go back to a baseline? Well, that's so there's like a dosing kind of comes. So you titrate them in. So Bob, this gets back to what you want to do in terms of health treatment. If you titrate people in on really expressive taste, so you get them over the line, and then they can make some decisions once they're sort of now on the over line and they've realized that this is pretty cool.
Just for the record, yesterday I went to the grocery store. I had to make something, and I had to be there right at 7 a.m. because I had to make before my son left school at 7:45. It's like that whole thing. And as I was walking down, I was looking at the end caps because I had walked by all the stockers and I saw what they were stocking. And then I walked by the end caps and I literally thought, what would happen if you took those beautiful trays of veggies that Bob had at our unconference and had end caps? I mean, I know this is not at all feasible, but I was like, just beautiful, beautiful veggies that were like, wow, that right, not like this like piece of broccoli in plastic that's like, right? But like what Bob shared with us, like you couldn't help but want to try what was on there. And I was like, what if we could do that on end caps? I know I'm digressing.
We do it in New York City. In New York City, you walk down the street and every grocery store has the most beautiful, lush papayas and fruits. And also, Dr. Ron Stout and I had an interesting conversation yesterday, and he said there's 4 things more that change a life, and one of them is environment, and that is that grocery store, and that is exactly what you're talking about. And we do know that shopping marketing is really driving a lot of the consumption and the purchasing behavior. We know. Yeah. So yeah, you're dead on.
So do we have more questions, or can I dive off into a different subject slightly?
Alan had a point. Alan said, who's the market? You're kind of hitting on that. Who is in the market to help local markets? Consistency seems like local farmers will need help, thinking Clover milk. How much is 10% of hospitals' food volume versus the capacity of small farms? And so I know you're going to dive where you're going to dive, Carter, but the one area that I do really want to talk about, let me say this, and then you go where you want to go. We don't have to go there right now. What really struck me in this, there were kind of 2 main pieces to this event and just what was announced and what we listened to in the very beginning. What I read in the beginning and then what we heard was 2 things really stood out. And I'm going to talk System C here. Was one, if System C, if those of us that want to refocus the economy and build the economy around human outcomes as opposed to cheap calories and monetizing sickness, right? We want to build that parallel system. This is an opportunity to do that with money from System B. Okay.
Yes.
My hesitancy of not acknowledging that, particularly folks that dig their heels in around the partisan and the people and the players and all that, is that if we just say, well, that's not going to work, right? Or 5% isn't enough, like these, right? Is System B is just going to take it and run with it. System C is going to figure out how to jerry-rig, like they always do, around capturing that money in a different way. And so, like the Power Mac example that we wrote about a couple weeks ago, right? Which our own AI agents, who we thought were trained on System B and C, fell for, which is like you take an unhealthy product and you package it to look healthy and fortify it or whatever. And then now you've got a System C product, and that's not the case. And so I think that as much as I say it's an opportunity, it's also a risk if we don't run after it as aggressively as the incumbents will run after it. So that's one. And then 2, which is really layered into this, is if we don't take advantage of this on the human outcomes piece of this, which we've been hitting out on the fringes in this whole conversation up until now, we can't demonstrate the power of what we're talking about. And again, it's a huge opportunity, which is if we're going to make the claim of nutrient density, how are we going to show that? So if a hospital all of a sudden is supposed, now, to me, following the DGA guidelines is not delivering nutrient density, medicinal quality food. Like, there's a disconnect between that. But if we can say to a hospital, well, why don't you double down on nutrient density? They're going to need somebody like Eric Smith and Audacious. They don't even know Eric exists, to say, hey, you could actually not only do real food here, you could actually measure the outcomes of that. And then you could tie this new requirement back to readmissions, right? And readmission penalties and average length of stay. And because the patients we're talking about that really need this healthy food the most, I mean, everybody needs it, but the ones that you're talking about, Maura, the diabetics, and those are not folks that hospitals want in their beds. They want those are not highly profitable bed stays for them. They want those beds for other reasons. So this is a win-win for the hospital of managing the volume of what they want and the patient mix in those beds as well. I'm done. Thank you very much.
If I could just read off exactly what is in this alert so people get a little bit of a sense.
And then we have a very big comment, long comment from Nicole McDougall.
Okay. So the key elements of the DGAs. Okay. I'm just going to read directly from page 2. It says explicit, limit ultra processed food options for patients. In other words, there is no ultra processed food in the new triangle. So in a way, Power Mac is white. Elimination of sugar sweetened beverages, unless clinically appropriate in limited scenarios. Elimination of refined grains, replace them with 100% whole grains. Prioritize minimally processed protein sources, including plant-based options. Emphasize veggies, fruits, legumes, nuts, seeds, seafood, and healthy fats. Yay. Emphasize baked, broiled, roasted, stir-fried, grilled vegetables and proteins, and eliminate all deep-fried cooking methods. Whoa. Eliminate processed meats and foods high in sugar, sodium, artificial additives. Ensure meals contain less than 10 grams of added sugar when clinically appropriate.
So Nicole McDougall says, the gap between the percentage of products in Florida grown nutritionally. Now this is interesting because it says without synthetics. So that brings up a whole other thing. And what we haven't talked about is Florida may be one of the biggest crop producing food, state.
That's right. That's why they picked us.
Mm-hmm. The sugar kings rule a lot of that. Like, sugar is king for real in the state of Florida. So I'll just kind of, just know that's a dynamic here.
Big Ag is king and sugar
Big Ag is king.
Big Ag
and not
the Big
necessarily
Ag.
this, and definitely not System C Big Ag, right? Versus, so the gap between the percentage of products in Florida grown nutritionally versus the products grown for the commoditized system is massive.
Correct.
Massive.
Yes.
In order for there to be a reliable supply of nutrient-dense foods procured into the healthcare system, the infrastructure to meet that scale has to be funded and integrated in a way that does not place burden on those growers or transitioning to regenerative practices. Without the closure of this gap through innovative funding and infrastructure mechanisms, we risk the 5% being reinforced back in commoditized systems simply for the sake of reliability of supply. That is exactly what I was getting at with my diatribe. Is that is that it's not exactly, but that is the Florida. That is a very, very specific.
We're Big Ag.
Exactly. And then Bob points out that the total dietary expense for U.S. hospitals exceeded $2.6 million per hospital on average, totaling nearly $15 billion in 2022.
So 5% of that would be the shift. So it's a number, but it's not. Yeah, so building on this a little bit with the comment there and going back to there are reasonable reasons to have arguments around the DGAs. As you read it, Maura, that's a pretty good way to deal with that ambiguity. Where some people are like, look, the new DGAs were force fit. There's a little bit of that argument, and that has some merit to it. But the way that was written is like, let's move in this direction. And so I think there'll be general agreement on that. Practically, what does someone do at the hospital the next day? They call their Cisco rep and they say, I need to source fresh local.
Yes.
They never said that before.
I talked to our Cisco rep, Lucila, and we're part of South Florida. There's like 8 counties that's all under this one president, and they already have local farm mapping sourcing. So they already do it into Sodexo.
So what's going to happen next is they're not going to change who they procure from. They procure from those people, and so that's going to just open up that component of that supply chain. As we think about we know what needs to go on next, and this alone, there are other programs that are addressing the transition, and then there are other. The misnomer out there is that fresh regenerative is more expensive. There are people that are delivering fresh and regenerative or regenerative commodity at a lower cost. So
that's our farmer. We have East Coast farms, and they pack boxes for us, and they are $14 a box, and it's a 3/4 bushel box with a mixed set of vegetables, fruits, and even some herbs or spices like garlic. And Ellen herself has enjoyed some of those boxes. And the problem is it's not always a lot of variety.
Maura, I never told you what happened with the box. So okay. Maura insisted, Carter. So I went down to record the graduation.
Because it's good stuff.
And Maura insisted that I take a box. And I was like, I cannot take a box. I want these people here, your graduates, to have a box. I was like, Like, this is right. This is really hard for me to take a box. And then she was like, how about your dad? And I was like, all right. Cause my dad, you know, he's on a budget. He goes to Walmart to buy his organic produce. And so I was like, okay, right. So I bring in this is actually funny. Neither of you know the story. So I bring him this beautiful box. I mean, and it is a beautiful box, Carter. Like, I need to find a picture to show you guys, but it's like beautiful box of produce. I bring it home and I'm so proud to give it to him. And I said, Papa, I promise I'll help you cook it. Like, we'll make a week of it, right? Well, you guys know my schedule. My dad knows my schedule. So he's like, no. Well, unbeknownst to me, he took it. You know, my mom lives in an assisted living. She sleeps there. I mean, he picks her up every morning, but you know, they cook for her, you know, for the residents. There's 6 of them. He took that box to the assisted living, and the staff was overjoyed to have that food to cook for the people, for the residents and for themselves. I mean, overjoyed. I went in to see my mom like the next week, and Miriam gave me the biggest hug. And I said, well, I'll have to pass this on to Maura because it was her. And she told me, I don't care if the greens are going bad in your house, whatever produce you're not going to use, send it to me. I will cook it. People want food.
That is, so that's in Garcia, that's East Coast Farms, and she's a packer house for farms all over. So the medium-sized and smaller farms like load into her, but so do the big dogs, you know, with all the peppers and the tomatoes, like from all over Florida. So she's actually a packer house like that. But we also met another one at the event, and it's called the Farmers Alliance. So Farmer Dustin was there in the room with me. He wasn't at the round table, but he was sitting like next to us. And he's from the west coast of Florida, East Coast Farms from the east, but Immokalee, Naples, all of that area. He's like ganging up little farms and putting them into connected networks. And so is Pasco. The Access to Fresh team is starting a hub there to be able to do the same exact thing. We do have, you know, challenges with how do you aggregate them into meaningful sets. But then also Alachua County is funded a study, and they're starting the county money to start their own hub to allow medium-sized and local-sized farms to load in. And it's all for food is medicine, food is health. Like, the entire purpose of it is to create these supply chains into
exactly. So that's what I was going to say. So Carter, I don't want to take away. I want you to keep going, but I do want at some point I would like Maura to talk about how she has structured Florida. Her approach to food as medicine in driving the state of Florida is not the typical, I don't think at all, the typical food as medicine approach. And it is part of why I am just a huge fan of Maura and want to see everything she's doing succeed, because I believe that Maura is really she is working to build the kind of infrastructure we're talking about. So you don't need to go there now, Maura, but Carter, as part of this, I think it would be helpful at some point for Maura to talk about that.
I think we should go there, and I to sort of finish a bit of what I'm saying is that the architecture we have an architecture that delivers food right now, which we've built over 70 years to deliver scale and stability and price. I think people should start thinking of a world in which the consumer is understanding price in the context of food and health, not just food. They are thinking about longevity. So their price elasticity, what they're willing to pay, I think is actually broader and wider than many people presume, and no matter what their economic level. So let me restate that. They are more than capable of understanding the value of better food to them than anyone else. And the opportunity exists in a $100 bag of grocery. $14 of that is the agricultural product. So the cost of moving it through the supply chain, packaging it, convincing you to buy it, getting it to the store, positioning for you to handle it, dealing with waste, all of that adds the other components to the bag to get to $100. So as I think about this as from an investment standpoint, an entrepreneurial standpoint, We have customers that are willing to shift their spending from healthcare to food. They have price elasticity and are willing to change if they see value. We have slack in the supply chain of how that money is spent. There will be opportunities in which the local supply chains, because they deliver better nutrition, that's their competitive advantage, for them to move in. And things like the cost of regenerative, the cost of agricultural product is a marginal difference against that $100 bag of grocery. If it costs $1 more, it's nothing in the whole scheme of things. That there's more than enough room there for it to work itself out. Now, we spent $18 billion trying to rebuild the ag supply chains ahead of consumer demand and failed in that $18 billion of investment.
Oh, wow.
We didn't fail exactly. It's still there. The technology's there. The movement towards regenerative, it's there. I think where we fell short was not consumer demand. Some people said, well, people don't want to eat this. I think where we fell short was as we got closer to that consumer demand, we botched it up and got stuck in these system B systems. So I think that there's one of the things that this does on the announcement side is it creates 2 new demand points that can shift. There's a spillover benefit. I was at the hospital, I had better food. Maybe I should eat better food at home. So there's a spillover benefit. And that I think we should, for those people that are entrepreneurs thinking about this, lean in and don't say, well, I can't move forward until we fix how to get regenerative costs down. Don't waste your time on that. Focus your time on exposing the consumer demand and exposing that if people eat better, they have better outcomes. If people see that they have better outcomes, they will pay more. No matter who they are, they will pay more. And that value can move back into the supply chain to help rearrange the supply chain to deal with that. And the money overall will come out of healthcare and move over to food. That's it's a pedantic sort of like professorial kind of thing. But you are working this out. So tell you, I mean, I
think we're about to see it in Florida because Healthy Snap starts on 4/20.
Tell us about Healthy Snap.
You're on mute. Ellen's on mute.
Yeah, I'm on mute. There's thunder, so I didn't want to distraction. Okay. And then the dog gets upset, and she's like attached to me at the moment. Nicole McDougall Carter said yes! ! Agree, yes. Carter.
And I think we're going to see this in real time play out. So really, we need a lot of eyes watching what's happening in Florida with the Healthy Snap and how they measure the benefit of it and the consumption of it, what people are purchasing with it, and then actually what happens in their bodies. Because so April 20th, Florida is rolling out Healthy Snap. And what that means is no sugar products at all, no baked goods, no sugar drinks, no Gatorade, no like protein shakes, no anything, no chips, no cookies, no sugar, no candy, nothing. And it's the toughest standard in the United States, the definition of which these classes of food have been limited by, has the greatest restricted product list of anywhere in the United States. So
that's the Florida Snap got a waiver and now they call it Healthy Snap.
Yes, sir.
Okay, keep going.
And you can look it up, Healthy Snap. You can look up the Healthy Snap and you'll see they have a page for consumers and a page for retailers. When you go into the retailers page, you'll actually see the breakdown. They give you brands and lists of like what is eliminated. You know, we will not be paying for this in your carts any longer. And so we had a fireside chat at the end of the HHS RFK event with Holly Freistadt, who's a food systems expert from the Milken Institute Feeding Change, and also to my left was Dr. Padmaja Patel from the American College of Lifestyle Medicine president. So these two were weighing in on what do we think will really happen with the Healthy Snap in terms of like consumers' purchases and consumers, you know, health outcomes. And there was some really interesting feedback, but I think this is when we're going to really the rubber meets the road, because 1/5 of all groceries purchased in the state of Florida are purchased with those EBT cards. Okay. That is a huge dollar amount. And that's in the Publix, that's the El Presidente, and that's the bodegas, and that's the little grocery stores at the end of the street. Right. So we're actually going to see a lot of things shifting for these families. And, you know, they could use their own dollars to continue to buy Takis at the dollar store, and they probably will at first. We don't know. Let's find out. But there's going to be more purchasing power behind the fresh fruits and vegetables.
And
now
was that done out of who? That was done. Who controls SNAP in Florida?
It's called the Department of Children and Families. It's DeSantis. It's Governor DeSantis's team.
But it's not. It's on the healthcare side or the ag side?
It's actually, ag is a completely different department. Healthcare is another department. So that's FDAC, Florida Department of Ag. And then you have ACA, which is the healthcare group. And actually the ACA secretary was with us. Secretary Harris was with us in the room with RFK as well. But in the middle is the Department of Children and Families, and that's a different secretary. And we work with Heather DeFrancisco, who's wonderful. She leads up this innovation team that's trying to push this all out and bring it to life across Florida, really with partnering directly with these retailers in so many ways.
And because there is a strong sugar lobby in Florida, have they sort of said anything here, or do they, hey, it's just Florida, we actually export our sugar, we don't care, or what's?
This is a good question. Are you going to get me in trouble, Carter? But
well, here, do you want me
2 years ago, we had a bill in the House, in the Senate, in Florida by a doc who was like, no more sugar sweetened beverages. And so they kind of dipstick tested it and gave him a warning. Senator Rubio is from Florida, Miami. He actually wrote a strongly worded letter that was like, no more sugar sweetened beverages. So this has been loading in over time. And one of the things that Trump did in working with his, they have a marketing budget, a marketing allocation for sugar. And Trump, when he was doing his international tariffs versus U.S., okay, he actually counted the Dominican Republic crop as part of the U.S., so it covered their marketing as a marketing addition. So they're already funded through certain pathways that I think we've been building into this, and I think it's about time that we finally got here. And I think there's been a lot of back negotiations in order to get us here.
Which just in all cases where we are changing things on an industrial level, which has got its own, people have established organizations. They are trying to protect them, which is sort of that's their responsibility to do. We have some hospitals that are leaning forward to say, let's fix food, and in a sense, to cut their own revenue off in doing so. And then we've got places like sugar, and sometimes you think about food systems and you say, for example, we've figured out how to take the feedstock for fructose and flip that over into a rare sugar, which is healthier. So with like allulose and tagatose. Okay. So there are ways in which to use the same stock. I'm not sure in sugarcane what the alternate choice there is. Certainly sugarcane is a better structure of sugar than fructose in terms of human health. But we've got some real challenges ahead for established industries who are going to hit the end of the line here.
I think one of the interesting things about the DGAs was it actually revealed in the document. So behind the picture was like a 10-page document. And if you go into there, it actually starts to talk about the culprit for diet-related disease causing the metabolic dysfunction is not sugar, it's ultra-processed foods. Okay, these are like the lab creations that are like, lab coat guards are like, let's dial up savory and add salt. Oh, we need some more fat so that dopamine hit is like ding, 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 ding. This is ultra-processed foods. So it kind of takes sugar out of the bullseye, the bullseye, because when you put ultra-processed foods in your body, it's the same as sugar. So refined grains are what we're over indexing on eating. That's what Dr. Mozaffarian shared, yesterday on one of his.
And there's a lot of evidence in this direction. I just want to be a reminder to folks that the bigger change that's going on here is NIH's annual budget is around $49 billion. For the last 30 years, they've concentrated all but about $1.5 billion on acute disease like cancer.
Right.
Their annual budget of the $49 billion, their annual budget focused on nutrition was, $1.5 billion and so. But even within that, their focus on nutrition has been more about nutrition related to like cancer, not nutrition related diabetes. And the chronic disease components represent 80 to 90% of our healthcare spend.
Right.
So if you're sitting there running FDA, you really have to sort of say, look, if I own the cost of healthcare and I'm spending 95% of my research dollars, or not 92% of my research dollars on things like cancer and genetic, but not 80 to 90% of my healthcare cost is chronic disease. You really, I think there's this point where somebody has to say these are not in balance. Yes, we'd love to solve cancer. Yes, there are a lot of tragedies in cancer, but a lot more people are dying of chronic disease, or their health span is being affected by chronic disease. So,
and you don't just have cancer one day. It's accreting over time. It accretes mass over time. And that's in a chronic conditioned body, right? So we actually see there's a lot of comorbidities related to leading up into that cancer acute state. But the chronic conditions, like you said, are eating up all the budget. And so how come we're not going after them harder, other than just put insulin in your veins, to bring your blood sugar down, which doesn't actually solve the root cause or even adjust for the problem.
And so unfortunately, we've got some pretty good hints about where these nutritional components fit in, but we still don't know the degree that processed food or certain sugars or certain gut microbiome does or doesn't affect the endocrine system and how it affects inflammatory response. We don't have a good specific inflammatory response markers to be able to test. So we've still got a lot of work to do there to figure out what the right food mix is.
Yeah, because the immune system is so sophisticated.
So we have a couple comments coming in. And then I'm actually thinking that I might want to show, I've been kind of playing around with some of your graduates. And there's one in particular that I might want to show for a minute. I mean, I know we only have 15 minutes left, but there's one in particular I think I could show a minute or two that would really kind of blow the socks off of everybody in terms of what and I think it goes back to Carter, your kind of aha a little bit of, you really do a good job in the program with the food. You really double down on that part of it. And it's sort of like giving, I mean, this isn't the best example at all, but, giving brand versus generic, that's still a dumbed down version, but it's, that premise. But, so Michael Hemingway says, why are there so many mixed and contrary messages nowadays about what is healthy and not for the same foods? I think that's a very valid point. And I think to me, it stems from what Carter just pointed out, which is like, we just don't have the data, right? Like that's a big
challenge.
We
have the data. That is not true.
We do. I know, but
we have the data that healthcare in a direction where you can get
wants to see the data. So I'll just leave that. But let's not. I don't want to get too caught up on that one with the limited time we have. Peter, our buddy, Peter. Maura froze up a little bit. Says there's also the spillover from farm to school and educating families on eating healthy that can drive consumer demand. And that's huge. We haven't talked about schools at all. So that's, and their program really does do that. Nicole is very focused on kids as well. And then Michael says we act as if groundswells are not also affecting the organic.
The way the DGA is applied to hospitals is going to be very similar to schools.
We act as if groundswells are not also affecting the organic farms.
Groundswells being other movements.
Yes, I believe so. I mean, Michael, if you want to clarify that, let us know. Hopefully Maura makes it back in. So I'm going to play this for a second because I think I don't know. I thought this was interesting. And then I'm going to find a clip for this other woman, but this is Maura's program, her Food is Medicine program. Let me pull this up. Maybe I can't. Here it is. Okay, you see it okay, Carter, I assume? Yeah. Oh, there's Maura. So I'm going to hit just this for a second. This is what I wanted to have for you, Maura, to be able to hand over to RFK. But I couldn't pull it off. But let's see here. Why are we now? Wait, here we go. Making America healthy again. Sorry.
We're the White House. We'll to sit down with RFK Jr. or the White House and talk to them about, after being in a program like this, about making America healthy again.
My recommendation to the White House would be that making America great is important, but making America healthy is even more important, because greatness is achieved by healthy consumption. And whether we believe it or not, these programs do make a difference. It increases diversity, and it gives us hope. So we can work towards prosperity, because a person who wants the optimum health can make the best contribution to our society. My recommendation is we need to find ways to make these programs be sustainable for the foreseeing future, regardless of affiliations, political or otherwise. People need help. People need help. So let's focus and let this work and make America healthy again.
And what would help after a program like this, keeping healthy?
After a program like this, what I would recommend is that we, as in my case, I come back after each attainment, because there are different levels to health. There's mental wellness, there's physical wellness. And we should have programs, maybe it's just outsourcing programs, by where we consume or purchase our foods, pamphlets. We can use the internet. To explain to people, say, okay, once you've made this step, now you got to maintain it. So the government, whether believe it or not, people do believe in the government and look forward to their assistance. So I think if we can come together, form whatever programs.
There you go. I'm going to find the other woman that, the one that lost all the weight. But anyways, so, I mean, I'll do that another time. I won't distract us today, but I mean, that's who this is and he's how many times has he done your program now, Maura? 2? Right. And at the graduation, he shared that he goes to the gym now.
Oh yeah. He lost 36 pounds this time. The first time his A1C came down 4 points. So he's lost 4 points. 4 pant sizes
so
this
Carter,
time.
Your $500,000.
Yeah.
His A1C came down in 4 points in how long, Maura?
6 months.
And now he goes to the gym.
Oh yeah. And he's 65. Looks damn good.
Yeah. Yep. So Carter, how do we take? Yes. And then how do we take advantage of this? How do people in our tribe, do we need to have an unconference around this? Do we need to what do we need to do around this opportunity of hospitals need to source local and hospitals need to?
I think I don't know the answer to that question. I think it's a fairly straightforward process of hospitals working through how to source. As I think about what I don't know, I think a 5% demand sourcing is a straightforward logistics problem, and for people that are producers, a process of trying to figure out how they get connected to that. So it's in our ecosystem, but I always think about us developing new technology. It feels like this is more of a ground coordination thing, so I'm not positive. There's some opportunities in digital tool sets to help manage some of that sales and distribution, but I generally think that the Ciscos of the world, or the Sodexos of the world rather, are going to be the ones doing this service.
How about the health outcomes on the other end? So the food goes through the supply chain into the health system, and then the humans, are eating it and consuming it over time, and their health is changing over time. I mean, like the ROI tipping point could be identified to the day, if we actually had brands like yours, Carter, helping us solve for those things instead of putting a continual glucose monitor on and waiting to see what happens there.
Yeah, I think that's good that you point that out. So what we're doing with HoloBiome, which I don't think is fully announced yet, so I'll be a little vague. There is an effort going on with ARPA-H, with Alicia Jackson's efforts to create a very large panel around measuring metabolic outcomes.
Yeah.
And what I would like to do, and it would be good from a hospital system standpoint, since they already have the diagnostic capability, if they could lean in and try to put a longitudinal control arm around this effort, that it would be, maybe this is something we could do with your team in conjunction with the hospitals and say, let's do some studies around this.
Yes.
And let's understand where it works and where it still falls short. I think that I don't know exactly next steps on that. I do know that something we're thinking about is how to build a very large, like close to UK Biobank-like control arm that touches all elements of the healthcare system and better understands the degree to which food falls into the various care modalities.
That's interesting. We have a UF Diabetes Institute at the University of Florida that has just gotten a bill passed that lets them be the master data keeper of all diabetics across the entire state, through the HEDIS data. And they're running like before and afters on continued glucose monitoring. Anyway, Dr. Ashby, there's some connective tissue there where we could actually like cross-pollinate, and you can learn from, and we can like access kind of before and after among Florida diabetics.
So I think, Alan, your point of unconference, I think we've got on the agenda to do an unconference around the topic of human-based outcomes. And I think that if we can show human-based outcomes and tie it back longitudinally to the source, the more that we can do that, the more we give consumers, patients, the capability to understand before and after. And the more we give to established companies and entrepreneurs the data that says, look, if the outcome changes in this way, what people will pay and what people will ask for changes, and therefore let's give them better products.
Yes.
And the failure of the $18 billion we spent on ag tech is really because we moved before that information was available. If we can now expose that information, then the capital markets will step in and fuel it more, just like they fuel AI. But
it's the same with health tech. We've written billions off on point solutions. And I would argue that a great number of them, just like the ag investments, a great number of them are absolutely essential, that consumers would eat them up, but that they don't have the connective tissue and they don't have an economy in which to live.
Yeah.
Because until we have a human outcomes, and that's why, so to your point, Carter, I guess that's why I will push back a little bit. And I mean, Peter said the innovations and the infrastructure connect what already exists, which was your point, not new tech. But I think that's a big part of Cressonia and system C and the network integration layer that we're building through Food is Health, is that we need to be able to connect. I mean, we know what Bob wants to accomplish with Chef's Garden. We know what the healthcare company wants to do. We know what a hospital now has to do. And so if we mobilize people and use cases to go to Advent, for example, in Florida and say, hey, you could talk to Cisco, right? You could do the Cisco route, but you could also take Maura's nutrition cap. Like we could mobilize something and say, or you could take this solution that solves the same problem for you. And we've to this point, we've already connected what already exists for you, and you could use us instead of Cisco. Like, I guess that's
Maura. Is there a quick argument that hospitals will say, wait a second, I don't know why I'm doing 5%. I should be doing like 10 or 20%. Like, do you think though, like where in this
their
journey
dials are related to these 5-star ratings, the star ratings, and the star ratings are determining how the CEO gets paid all the way to the stock value, all the way to like
the biggest piece. So I mean, the biggest piece in there is readmission penalties.
Yep.
I mean, that is the biggest.
Also have star ratings against food and what's food served. So anyway, I think that it's beyond just a P&L for the food and beverage, line item budget. I think it actually spans the lifespan of the entire hospital. And then super in Florida, it's very competitive with other hospitals to the right and left of you, like which one you're going to go to, and food is a big part of that. So actually, if you kind of like lift up, you're going to start to see it's like incremental complexities. But one of the things that I think is interesting, Carter and Ellen, is that telehealth and all of this data set that's been collected and being collected in telemetry in hospitals, and all of this information sits behind these, HIPAA walls and the walls of the privacy with the docs, and consumer wearables like crush that wide open, because as soon as you click, I consent, and the 17-page document is behind there, they're actually pulling and pushing data and doing different things with data. And like, we're hoping to build a food as medicine DAO where we're actually feeding people and then aggregating the telehealth data up from these consumer wearables into dashboards and make it visible, right? Like let's start to be responsive to what's happening in consumers' bodies and not hold it behind the doctors, offices that aren't always looking at it, and the consumers don't really understand it. So by surfacing it and leveraging it, you can actually leverage that human-based outcomes, map it back to the economic data.
Oh, totally. It's putting all of these pieces together. I mean, that is my soul. Like, I feel like that is all I think about now, whether I'm sleeping or I'm awake.
The data's there. It exists, and we already have it. It's just access to it.
With that, I have to leave.
Okay.
You guys can keep talking, but I have to do a call.
No, I think we will see you later. I will close this down with Maura. There's one question that Maura, I think we can answer. Thanks, Carter.
Thank you, Maura.
Bye. Good to see you.
So Michael Hemingway says, so we're certain that the correlation between health and eating is more than personal and individual choices.
More than what? I'm sorry.
And more than personal and individual choices. I'm a 63-year-old man, and I'm concerned that I'm just padding. And he's talking about fattening with useless carbs and polysaccharides and sugars, then I'm just padding my cardiovascular and endocrine health.
Mm-hmm.
And I mean, if I'm answering this correctly, I would 100% agree that like, that's the problem we're running into, is that our industrial food system, that's the natural order of things. That's why Carter talks about pre-chronic all the time, is that we are all basically on a predetermined path of chronic disease. If we don't actively jump in. I mean, to me, that's the inherent flaw in all of this, is that system B is the way that we are operating, which means cheap calories that then leads downstream, right? That tractor beam into monetizing disease. And again, I don't want this to come across like some sort of weird conspiratorial finger pointing. We designed the systems exactly as we intended them, like exactly as what they needed to be.
They're highly profitable. They're highly efficient. They're at mass scale, and so they did all the things that the capitalist profit drivers needed to solve for
famine, right? Right, and then we wanted to keep people alive, and back when those systems were initially scaled, there were very different problems than now. We didn't understand the unintended consequences that our solutions back then would create generations later at the end of the century.
I don't think
and so,
this
right, or the beginning of the next, right. We didn't understand what 100 years later would look like, or 60 years later, or whatever. And so, you know, and then Michael Hemingway says, I listen and read about HHS recommendations where it seems as if doctors are diagnosing 100% nutrition related illnesses. So I am going to address that with statistics, Michael, because I do have some statistics to throw that out there, which is that some of the most recent data, this is not HHS. This is, you know, Tufts data. This is NIH data. I mean, I guess you could say that that's HHS, but, you know, other studies is that 90% of the 5.3 trillion that we spend on healthcare is related to chronic disease.
Wow.
So that means that we are spending about $4 trillion annually on chronic disease.
Yep.
Tufts did a study where they determined that 85% of chronic disease was diet related. And I think this is where is where there is a lack of insight and information and knowledge, which is, that's why I have this hat. It's as if Michael wanted me to point to my hat.
We love your hat.
Mitochondrial health is where it starts. And mitochondrial health dictates whether or not you have chronic inflammation, and then all of the things that downstream occur when you live with chronic inflammation. So when we talk about useless
one cause
carbs,
of chronic inflammation, instant.
Correct.
It's a poison, it's a toxin.
Chronic inflammation. So like people say, oh, diet related is only type 2 diabetes. No, there's actually research that says, and not just influencer
Alzheimer's,
research, but cancer, dementia. My mom has vascular dementia. She is dying early. Autoimmune. I've dealt with that, right? All of these things. But so there are systemic reactions to mitochondrial dysfunction. It is metabolic dysregulation. It is hormonal dysregulation. It literally all comes downstream, and then it promulgates in all different conditions.
So it's all of it.
Correct. So I just want to be clear that
what we put in our mouth,
I'm not trying to be some right. But the reality is, mitochondrial health is not this easy to solve, hand somebody a pill, right? It does become nuanced
shots in the
correct.
Farm.
Well, I mean, yeah, I don't want to go into the interventional component. I want to stick at the food level, right? Which is to say,
take ownership.
Michael, you're 100%. Like, we have the data that says that about 3 trillion. So let me just say this, we can kind of close it out in this, and is that there is about $3 trillion of downstream revenue to the health that right now, it's $3 trillion in our economy that is given to downstream treatment of upstream decisions and an upstream system. And the beauty to that is not, we tend to get caught up and say, healthcare is evil, they're taking $3 trillion. I look at it differently, which is, that's $3 trillion that we could redistribute.
Yes.
Because the food industry, the farmers, right? Retail grocery, you talk to any retail grocer CEO, they could care less if they sold Doritos or broccoli. What they care about is their business model, which right now comes back to the shelf space and in cap and all, right? You're basically renting shelves. I mean, that's
who pays them the most, right?
Correct. So everybody should be interested in getting that $3 trillion and not just making it a predetermined,
like loss leader. Yeah. Like a loss leader.
Correct. So I just like to say, yes, there is a $3 trillion diet related healthcare burden spend that we could redistribute. So when we talk about wearables, we talk about, right, all these different things, that's a plus. There's already 2.6 trillion in the food industry.
And even my client knows this. Even Courtney, my client, is saying human capital is the most important capital.
Absolutely. And Katie Stebbins, if she were on, she'd be like, Ellen, you're only talking about the healthcare dollar about this. You're not talking about the productivity cost. And you're not like, there's so much more to this than just the $3 trillion
the assets
in
of our
downstream
country, our
healthcare
citizens,
costs.
our strength,
Correct.
our power,
Correct.
our ingenuity.
Exactly. Which is what your graduate said. He was like, health is prosperity, right? Now I'm going to sound like I'm like some sort of like motivational speaker, but I mean,
well, this is why it's about employers as well, moving food as medicine into employer systems to help them like change, like Angan and our county tax collector, whose health and premiums have never gone up in 10 years because she's paying attention to this with her employees,
and
giving them a test before and after and giving them nutrition counseling. It's doable.
Well, she said she's come on. You just reminded me. She said she wanted to come on the live stream with us. And I've been
as the healthiest staff
because
of paying attention to this over the years. Yeah.
So I'm just going to hit a couple last, I just want to make a couple of last comments here. And then like, just cause people took time to put stuff in here. Megan gave a shout out to System C and to our live stream. And I really appreciate that because sometimes I think that we seem like we're maybe insane and not really adding the value that we hope that we're adding for people. So I'm glad to hear that. Michael Hemingway reacted back and said, this is incredible. Can we seriously consider all of those brand name medications being advertised, which don't seem nutrition related, like Claritin, for example? I don't want to go down the over-the-counter piece, but I will tell you that the work that we're doing, like we have CPGs that have OTC products that, again, we're pushing to say, let's get it outcomes here.
Like
right?
Dannon,
let's not
like
just
the
try
Dannon
to sell the
yogurt
product.
research study they did. Yes.
Right.
Bio.
Then, and I could not agree with this more. He also said, like, people don't even know how they feel.
That's true.
My husband and I, when we go to Disney, this is what I say, because I'm a big Disney fan. I do still have children, so I don't count as an adult Disney person, but my husband and I have determined that we are going to be those people. I mean, we aren't going to be like, I don't think we're going to like dye our hair pink, but we will be at Disney when we don't have any children with us. So anyways, but when we go, this is literally what we say. I see people walking and I'm like, if there was a way to just let these people feel healthy for a day. Just let these folks for a day, right? Because I feel healthy. I get up and generally speaking, I don't feel like a truck ran over me, right?
The inflammation, the swelling,
I eat like a friggin' saint. I exercise, I do all the things. But I have my fair share of 5-hour nights because I'm addicted to this work. I'm not the endurance athlete that I used to be. I've shifted most of that energy over into this. I stay healthy, but I don't do what I used to do. But I feel good. And I think to myself, and that's what your graduates told me. They were like, I feel good. Like I get out of bed and I feel good. Right. And I would do anything. Michael, you're 100% right about that.
And then finally 4 and 6 weeks, by the way. It doesn't happen in week 1, doesn't happen in week 2. It takes a minute. It takes about 4 to 6 weeks and they come back and all of a sudden everything's shifted. All the water is off their feet. Like you can actually see the bones. Like it's a total transformation.
Agreed. And then the last comment, our friend Peter Contardo said, he said, appreciate you, Ellen, Carter, and Maura for moving this from policy signal toward real world action. And I will leave on, I want to land the plane on that note, which is Carter and I, Maura, I would love to see your coalition, like, and we can do this together, is like brainstorm around how we can kind of come as a more formal united front with this System C piece of sort of solving this human outcomes, coming with solutions to say, we have the network, we've solved for the supply chain, we've solved for the local farmer issues. We have the resource of, Emily Roach, who's been all over the country dealing with some of those local farm standards challenge with Morrissey Market. And I mean, we have Bob, like we have a network of OGs, right? Old guard leaders who have been pushing for this change, who all want to come together and see this. And like, let's use them and let's take advantage of this, I think, huge tailwind and opportunity and and show an alternative. Or if you want to go alongside a Cisco, fine, right? But whatever. But like, this is an opportunity to redistribute some of that money. So
yeah, well, let us be your little case studies. Let us be your, let us like learn from you and let us implement, and then you can follow us implementing and see how we roll. That's how we work with Tufts. That's how we work with Milken. And we love to be the movers and shakers in this space, so more and more people can heal.
Which is why you have movers and shakers meetings.
Yeah, we have movers and shakers webinars, and we have our next webinar. The big important one is the Farms to Food as Medicine. It's on April 15th. You can find us at healthandnutritioncoalition.com, and there you'll see the different. We have a symposium October 8th in Orlando at Four Roots Farm, and this Farms to FIM seminar. There's 8 speakers. It's a 2-hour. We're going to deep dive into this. The CMS and the farms and all the different money streams coming in for the farms for food as medicine. And then that's April 15th, tax day. And then the next month, May 15th, we're launching this new How to Heal Lab with Dr. Deb Kennedy. So the How to Heal Lab. So you can find all of those at
Oh, good. I'm so glad to hear that Dr. Kennedy's doing, because we talked about she needs to be out, like people need to know more about her. So I'm like really happy.
Food Coach Academy. Yeah. So we're going to do we're principal investigators, and we invite 4 different people with amazing, body education, nutrition education, tech and health systems, and then belonging communities. We want to feature each of these programs that we can all learn from in the How to Heal Lab.
Well, I would like to finish this by saying thank you, Maura. I love working with you. I love supporting you. I love everything that you do. I feel blessed to call you a friend.
Yeah.
I also appreciate you getting that event, you and Bree and AFPI. I appreciate you guys getting that event over the finish line, given everything that you faced. We all talk about people that give us a hard time on the surface for, just all of the political discord going on. But if people knew the back room slinging, it's nothing, right? And I think it takes people like you and Bree and the other organization to just stay committed to it. And I appreciate you making sure we were invited to be in the room, and we honored that. I didn't see it as an albatross. I didn't see it as something I didn't want to be proud of, because I'm not there to support Oz and RFK as, men or, whatever. I'm there to support our country, putting policies in place that accelerate the possibility of human outcomes. And to me, that's what I see this as doing. And so that's why I want to see this Food is Health tribe take advantage of that and not get caught in the other piece. Because the reality is the incumbents are going to take whatever is thrown at them and they're going to run with it. And if we want to redesign the system, we have to jump in there.
Yes. So. And you are a national treasure, and the time that you have committed to studying this problem as deep and as wide and as far as you've run with it, you and what's in your brain as a reverse engineer as to how to redefine this system so that it empowers and engenders health. I cannot wait to see what you do. Thank you.
I may not sleep much, and I'll go down this is what I always say. I may go down in a ball of flames. But man, did I try. I threw it all out there. What's that song? I lived, I'll look back and be like, well, I did everything I freaking could. So, my son's college counselor said to him last night, because he was debating about, he's still arguing about doing a Substack.
Oh.
No comment, right? And he's and she literally said to him, she goes, I'm just going to ask you a question. Because he really wants to go to Georgetown. And he should go to Georgetown. Should. And so said to him, can I just ask you a question? She's like, if in the fall, you open up who you get
here come the letters, accepted, not accepted.
Next year, right? Go through the application process and you don't get admitted where you wanted to. And you didn't do the Substack. Are you going to look back and sort of question whether you should have? And she's like, that's all. And I was so grateful for a third party to say that to him, right? And that's how I feel. It's like, I can't unsee what I've seen. And so to continue to just be a healthcare consultant that tries to go down the innovative path, but is still very much living in a system that monetizes disease. I want to work with even if it's an incumbent that's still in System B, if they're working towards what's needed for System C, if they're investing in that, they're pushing, that's what I want to do and build System C. So thank you. Thank you for your time, Maura. Thank you, everybody that's on. There's like this love fest at the end because Carter left. So thank you.
Thanks.
All right.